from Bayer side of this, welcome you all to this Bayer Eyesight meeting. And we are delighted to have you join us for this focused clinical exchange. Tonight's session bring together leading retinal experts to explore real-world strategies, treatment durability, and evolving approach to fluid management. At Bayer, we are proud to support platforms that foster peer learning and evidence-based care. Thank you for being part of this dialogue. Let's begin with the introduction of our speakers. Our first speaker is Dr. Pooja Sinha, and I'm delighted to welcome Dr. Pooja ma'am. She is a Chief Vitreoretinal Services at ABI Institute at Patna, and she's also a Secretary of Vitreoretinal Society of Bihar, and she has done her fellowship training at Shankar Netralaya, and she has also have international exposures in Oxford and Hull. She has dedicated over 2 decades in advancing retinal care, training fellows, and leading national and international instructional courses. Her contribution have been recognized with multiple awards, including the D.K. Bose Gold Medal and honor from Rotary and Unite for Sight. Ma'am will be speaking on the evolving role of aflibercept in PCV, APVRS insights, and comparisons with anti-VEGF agents. And our another speaker is Dr. Chitranjan Mishra, sir. Sir, it's my privilege to introduce you, sir. Sir is a head of Vitreoretinal Services, Academics, and Research at Trilochan Netralaya from Sambalpur. With advanced training from Arvind Eye Hospital and fellowship across India and abroad, Dr. Sir has performed more than 6,000 vitreoretinal surgeries and contributed over 100 PubMed indexed publications. His expertise spans diabetic retinopathy, ocular trauma, imaging, and AI applications in ophthalmology. Sir is a reviewer for 20 international journals and recipient of multiple national and global awards. Sir is widely recognized as a leading voice in advancing retinal science and educations. And Sir will be speaking on translating research into practice, real-world applications on DME management and strategies. And our next speaker will be Dr. Subhendu Kumar Boral, and it's my honor to introduce Sir. Sir is a senior vitreoretinal consultant at Disha Eye Hospital and a graduate from AIMS New Delhi with advanced training with vitreoretinal. Sir has been a cornerstone of Disha since 2002, specializing in complex retinal surgeries, including diabetic retinal disorders, detachment, and macular procedures. Sir is pioneer surgical techniques and videos atlases have earned him numerous national and international awards, including multiple U-Retina Best Video Awards and the prestigious Rhett Buckler Award from ASRS. Sir is a prolific author, educator, and invited speaker worldwide. Sir continues to inspire innovation in retinal science and surgeries. And Sir will be speaking on evaluating anti-VEGF drugs, molecular characteristic, and their impact on treatment success. So now may I invite Pooja ma'am to start her presentation. Thank you, ma'am.
Thank you so much, Nitesh ji. Thank you to Bayer for this lovely evening of learning and sharing. And very good evening to everyone. Am I audible?
Yes, ma'am, you're audible.
Okay. So I'll go ahead with my talk on the evolving role of aflibercept in PCV, the APVRS insights and comparisons with anti-VEGF agents. Slide me, Chandra. 1 second. Okay. Okay, so this is a very useful slide. Basically, the diagnosis of PCV is, as everyone knows, the SDSS OCT major criteria is the sub-RP ring-like lesion and fast OCT complex showing an RP elevation and the typical sharp peak PEDs. When you have the confirmation of PCV, we start with anti-VEGF monotherapy or a combination of anti-VEGF with PDT, which will hopefully be available with us in the coming months. Monitor the response with OCT plus minus ICGA with institutions that have it. And there can be either complete regression or a stabilized SRF complex. Then we gradually extend the intervals with the treat and extend regimen, or they could be persistent or recurrence of disease activity, where we can shorten the intervals with treat and extend regimen, combine the treatment with anti-VEGF and PDT, or switch to another anti-VEGF agent. Sometimes you have a large submacular hemorrhage where we need a pneumatic displacement with or without vitrectomy, or a TPA, or an active extrafoveal polypoidal lesions. These patients are lucky because we can go ahead with a thermal laser ablation with and anti-VEGF agents, and which completely destroys the polyps and has a better visual prognosis. So coming to the 2025 APVRS guidelines, it was stated and confirmed that monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. To date, there are no data exploring whether faricimab or brolucizumab monotherapy are non-inferior to combination therapy in patients with PCV. So this is a slide many of us are familiar with. Basically, aflibercept is a robust molecule with a binding affinity of 0.172 and estimated half-life of 9.1. And we all know the structural appearance of this molecule. So 2016, there were pivotal aflibercept trials which demonstrated that PCV can be treated similarly to neovascular AMD. And we had two trials, the VIEW-2 trial and the PLANET trial. The VIEW-2 trial, there was mean change in BCVA at week 96 that was studied. And it was found that patients with PCV and patients with neovascular AMD achieved similar visual gains with aflibercept monotherapy, as you can see in these pie charts. Then there was the PLANET study, which studied mean change in BCVA from baseline at week 96. And it was studied that PDT can be reserved as a rescue therapy for suitable patients. So PLANET study, we know, was a prospective sham control study, which assessed the efficacy of aflibercept monotherapy compared with aflibercept plus active PDT for the treatment of patients with PCV. So this was studied across 62 centers, and there were the 3 initial monthly doses of aflibercept 2 milligram were given. And then there was randomization of 1:1 with patients receiving sham PDT and patients receiving active PDT. And this was done over week 52 and 96. And this was the result that they got, that vision gains were maintained using aflibercept monotherapy with optional treat and extend dosing in year 2, as you can see over here. Complete polyp regression has also been observed across real-world case series with aflibercept and PCV, and a large case series is done with Japanese eyes, where there was a complete polyp regression across studies. And variability in polyp regression rates are also likely due to differences in polyp regression assessment criteria across different studies. As you can see, the various studies have been listed in. So the other promising drugs in the pipeline are faricimab, and there's a Salveen trial which holds promising results. There's a week 16 results from phase 3/4 Salveen trial, and this has dual Ang2 and VEGF-A inhibition, which is advantages to this molecule for PCV, and it showed a robust and rapid improvement in BCVA of plus 7.8 letters. And there's also complete closure and inactivation of the polypoidal lesions in 86% of the cases in majority of eyes. And it is also well tolerated with a known safety profile of faricimab. So in conclusion, aflibercept's 2 milligrams efficacy and safety profile has been established across random control trials and is supported by over a decade of real-world monitoring. I'll just share 2 cases which are interesting, and I thought with paucity of time I can accommodate 2 cases with PCV. My first case is a 68-year retired school teacher who presented with diminution of vision in the left eye since 1 year. He had received 3 injections of eccentrics earlier elsewhere. The best corrected visual acuity in the right eye was 6/12, but left eye was only counting close to face with a grade 2 NS. So this was the fundus picture of the right eye, which showed drusen and showed a normal fundus contour. And this was the left eye, which showed a massive subretinal fibrosis with an exudation and massive subretinal hemorrhage. And clinically, this picture is very characteristic of a PCV complex hiding below. So this was the OCT. You can see these sharp peak PDs, and you can see variable amount of subretinal and intraretinal fluid and a massive CNV complex. So 0.05 ml of aflibercept or Eylea was given under strict aseptic precautions. And this was 1 month after the injection, when vision had improved to 6/60. The lesion was definitely less aggressive looking. The fibrosis had decreased, the hemorrhage also had decreased, and the exudation had marginally increased, which showed us diminishing fluid. And this was the OCT picture. You can see on the below that the CNV complex also had decreased and the fluid had marginally reduced. And this was after the second and third injection. You can see that satisfactory foveal contour has been achieved and the CNV complex is markedly reduced. So this was a case 2 patient, a very interesting case that I encountered, 68-year male patient with diminution of the left eye vision since 1 month. He was also a diabetic and there was no other significant systemic history. On examination, vision in the right eye was 6/12 and left eye was 6/24, N12 and N18 respectively. And on slit lamp, there was grade 2 NS. This was the fundus picture of the right eye, which showed multiple drusen in the posterior pole with a few macroaneurysms suggestive of an underlying background diabetic retinopathy also in this patient. And this was the left eye, which showed few macroaneurysms and a small blot hemorrhage in the macula. And there was a thin rim of subretinal hemorrhage at the temporal border of the macula. There was also a massive dome-like peripheral hemorrhagic subretinal lesion in the inferotemporal quadrant. The FFA showed leaking microaneurysms. There was a blocked fluorescence corresponding to the subretinal macular hemorrhage and blockage of the choroidal fluorescence below the hemorrhagic mass because there was so much of subretinal hemorrhage. And there was also surrounding windows defects from the atrophic RPE changes. At this stage, I got an ICG done for this patient, but I didn't see any polyps. So this was the line scan through the macula. Luckily for this patient, this was a peripheral IPCV and the foveal contour was very respectable. And so the vision was at no times really bothering the patient. So this patient was managed with the ranibizumab given followed by laser around the hemorrhagic mass after a week in August 2024. And the injection was repeated in a monthly interval over 3 months. So this was the fundus picture after the second injection. You can see that the hemorrhage had decreased and also some laser I had done around the hemorrhagic mass because it was very much extra foveal along the arcade. And the vision also improved from 6/24 to 6/12 after the third injection. So you can see over here. But again, the patient reported in December 2024 when the vision was not so disturbed, was 6/12, but the patient complained of floaters and there was a thick band of subretinal hemorrhage surrounding the previous lesion. At this stage, because I had in the back of my mind that IPCV lesions can be very, very aggressive and bothersome, I gave the patient 2 injections of Eylea, one after the other over corresponding 2 months. And you can see that this was a CNV complex through the scan, through the peripheral scan that I took. At this stage, the ICG also showed this small polyp over here. You can see over here. And this was following the repeated injections. The CNV had regressed. And this was at the picture at the end of 2 months, when the vision was very good, 6/9, and the hemorrhage had subsided with subretinal fibrosis. However, all good things don't come to an end. And again, the patient reported in April 2025 with sudden diminution of vision in the left eye. At this stage, there was a breakthrough vitreous hemorrhage. And since the patient also had a progressive cataract, we combined a phaco-IOL along with vitrectomy and a peripheral endolaser and added another injection of Eylea. And the vision post-op improved to 6/9, and there was complete regression of the lesion with RP hypertrophy and hyperplasia. So just 2 slides on PEHCR. It's an uncommon degenerative process of the retina with subretinal or sub-RP hemorrhage and exudative mass outside of the macular region, and very well managed with the Eylea in this patient. Vision loss could be due to subretinal fluid, hemorrhage, fibrosis. You all know OCT is generally not necessary to assess PEHCR, which is too far in the periphery. It is useful to assess the extent of the exudation in the fovea and the subretinal fluid. Thank you so much for your patient hearing.
Thank you very much, ma'am, for your wonderful presentation. Now, I invite Chitranjan sir for his talk. Ma'am, can we take questions at the end of this session?
Yes, sure, definitely.
Can I ask one question, please? Dr. Puja.
Yes, sir.
Good evening, sir.
Yes, sir.
Okay, good evening. So what is the your idea about how they differ from the macular PCV and the peripheral PCV, like peripheral exudative retinopathy, whatever you have showed in your last case, as your last case. How are they less aggressive, or they more aggressive, or they have almost similarly like macular PCV cases?
Yes, sir. So this is a very interesting question. Actually, PEHCR, sir, the advantages are that the patient has very useful vision, and because it's not involving the macula. The patient does very well with sometimes even extrafoveal laser, and anti-VEGF injections have a limited role. Or if so, we give it, but lasers do a remarkable job in these cases. But the reason why I showed my case was that it was really aggressive. The lesion, though along the arcades, was again and again getting reactivated. There was formation of polyps, even though I had done a laser, aggressive laser. So at the end of the day, there was, because of the breakthrough hemorrhage, we had to do a vitrectomy. But otherwise, PCV lesions, because they're so aggressive, the hemorrhage component is there. So anti-VEGF agents are definitely required, sir. Even though laser may be effective, but injections are definitely have a role.
My take is something like different. I don't think is the progress of the peripheral exudative chorioretinopathy and the macular PCV cases, they don't differ that much significantly. One difference is whatever you told, that it is they are having a very good vision. So you have the time to do the laser or anything like but the moment patient presenting with the vitreous hemorrhage, that time it's very difficult to preoperatively diagnose the case as it is a peripheral exudative PCV. So this is the difference. Like you can see incidentally that there is peripheral exudative lesions and some kind of polyps in the during the intraoperatively after clearing vitreous hemorrhage. So that is the thing. So and they do respond quite nicely with the anti-VEGF, and you have the options for doing laser. But macular PCV cases, sometimes they are so aggressive, you don't have any time to do the laser also until unless they're extrafoveal.
Yes, sir. I fully agree. In my case, the hemorrhage occurred on a later stage. I already knew the diagnosis in this patient.
Okay.
And then there was breakthrough hemorrhage. So I knew what we were going to deal with.
Preoperatively, because you have seen
yes,
that.
Sir. Yes.
Thank you.
Should I start, sir? Subin, sir?
Yes, sir.
Thank you. So are my slides visible over there? Yes. So good evening, everyone. Thank you, Bayer. And it's always a pleasure to share the forum with senior surgeons like Dr. Subhendu sir, Dr. Puja madam, and excellent cases by Puja madam, as we have seen over here. My topic is translating research into practice, real world applications of diabetic macular edema management strategies. And what are the limitations of the clinical trial design and outcomes? Because all of us, we follow the ideal clinical trials, their outcomes, their results, and we try to replicate in our studies. But what are the limitations of these trials? Number one is strict selection criteria. That means very ideal patients. If like all of us who are involved in the studies, we know that there are so many exclusion criteria that it becomes very strict for the inclusion of the patients. However, when we see our clinical practice, it's not the same. We have to see almost all the patients we have to treat. They don't follow that strict inclusion criteria. Then number two limitation of these ideal clinical trials is lack of consensus on a ideal treatment regimen for the DMA. Like no clinical trial tells that, okay, this is the superior above all. And in fact, in practice, we have to make a permutation combination of these and we have to use it. And number three and most important is the results may not fully reflect the real world complexity of the disease and its management, particularly diabetic macular edema, where it is not limited to the ophthalmological findings only. Patient is having so many systemic findings which also affect the outcome. So with these limitations, we'll come to the current landscape of anti-VEGF in DME treatment. We have RISE and RIDE for the ranibizumab. We can see over here over 36 weeks. We have very good outcome of the ranibizumab and Yosemite and Rhine study for faricimab and for the kite and crystal study for the brolucizumab. So these are the current landscapes for the anti-VEGFs so far as diabetic macular edema is concerned. And if we see the efficacy of aflibercept for the management of diabetic macular edema, it is the VIVID and VISTA study where aflibercept was compared with macular laser, and it was found that aflibercept both 4-weekly and 8-weekly, it was superior to the laser thing. And the DRCR protocol T, that is a very important protocol and very commonly asked for the students also, where they have compared all the three anti-VEGFs at that time, like bevacizumab, ranibizumab, and aflibercept. Though all the three anti-VEGFs were found to be useful in improvement in vision and decreasing foveal thickness, it was found that aflibercept was better when the visual acuity, in present visual acuity, was worse meaning how much? Less than 20/50. So there is a need for the real world evidence to complement the data from the randomized control trial and support it, because only randomized control trial data, with that we cannot go with this. And of course, only real world things we cannot show it as evidence based medication. So real world model, it measures the real world effectiveness in the clinic, and patient population is unselected, diverse, so it kind of makes it acceptable, and it is not pre-screened, often presenting with a range of comorbidities, as I have told just before. And it's based on the physician's decisions, and diverse outcome measures can be done. And it provides essential information on patient impact, highlight opportunities to improve the quality of care and reduce disease burden, and worldwide differences, because disease is not limited to any particular geographic location, and the value of treatment also can be found out from this real world evidences. Now coming to the endurance trial, over the coming 3 to 4 slides or so, we will see some real world studies. So it was basically the extension of the VISTA study, where you can see after 3 years, 2 more years of extension was there for the endurance study. Aflibercept we are discussing over here, and for DME, and the significant findings were like 25% of the patients required no further injections, and 48% patients injected 5 or fewer injections. So endurance was an extension of this VISTA study, and it was found that the outcomes were better with aflibercept. In fact, the visual acuity was maintained in most of the cases. Now coming to 2 more studies. One is Apollon study. We can see the Apollon study over here, and we can see the RCT left side column, 2 columns. You can see it's the VIVID study, that is the randomized control trial. However, the real world study, the Apollon study, we can see 6.5 letter gain was there, and 52% of treatment naive patients received early intensive therapy. So this Apollon study basically found that aflibercept was effective in both treatment naive and also the eyes who have received other anti-VEGF agents. Moorfield study, it tried to study the mean change in visual acuity from baseline to year 3, and here we can see baseline worse than 20/40 and better than 20/40 in both the groups. We can see at year 3 the visual acuity improvement was statistically significant. Now coming to the Draco study, again Draco study, it is how it is different. It is like it says that meaningful vision gains or maintenance with aflibercept regardless of the baseline vision. It's not limited to only say good visual acuity or less visual acuity. Across all the eyes, it was helpful. And here we can see baseline visual acuity. What were the number of letters, and the mean change in letters we can see in the left eye, and mean baseline visual acuity 71.4 letters, and the finding was for more than 75% of the patients, diabetic retinopathy severity level remained stable from baseline to month 12. And here we can see data from the Moorfields Eye Hospital and the FRB registry assessed efficacy of aflibercept in patients in clinical practice. You can see over here mean visual acuity from baseline to month 12. We can see very nicely there is a poor baseline visual acuity is a commonplace in up to 2/3 of the patients in clinical practice. And if you can see the adjusted mean change in visual acuity across baseline, the adjusted mean visual acuity gain from the baseline to month 12 in eyes with initial vision of less than 68 was significantly higher in eyes receiving aflibercept than those receiving ranibizumab with a similar number of injections. That means it was effective in eyes with poor initial visual acuity. Now coming to something from India, again Dr. Devdulal Chakravarti et al. Aflibercept versus dexamethasone implant for recalcitrant DME in pseudophakic eyes, 1-year outcome from a quasi randomized study in India. And what was their outcome? Both the groups, that means recalcitrant DME, they have given this thing aflibercept versus dexamethasone implant, and both the groups improved equally at 3 months. However, intravitreal injection had 6.5 times higher likelihood of more than 3-line improvement, and of course, as expected, higher IOP was found with 13% eyes in the DEX group needing IOP lowering agent. So what was the conclusion? Both the groups had similar visual acuity improvement and thickness decrease in recalcitrant DME, and intravitreal aflibercept leads to more than 3 visual acuity gain in a meaningful number of eyes. Now coming to what are the society guidelines, diabetic macular edema treatment guidelines in India, the AIOS Diabetic Retinopathy Task Force and Beat Retina Society of India consensus statement. And here this study concluded that intravitreal injections of anti-VEGF are the first line treatment in center involving diabetic macular edema. And n number of trials have demonstrated that anti-VEGF therapy is more effective in improving vision in central DME than macular laser. Of course, macular laser have been very limited number of patients we give. The most common reason of non-responsive to anti-VEGF therapy due to inadequate treatment as per the above protocol. And in eyes with persistent DME and visual acuity of less than 6/12, a different anti-VEGF may be considered. And most of the times when it is bevacizumab, it is switched to ranibizumab or aflibercept in that order. Now coming to international recommendations, because in the past 2 slides we studied about India. Now coming to international recommendations and guidelines recommended in the first line use of aflibercept in patients less than 6/12. Here we can see aflibercept is the drug of choice in DME eyes with baseline visual acuity less than 69 letters, and it's superior to bevacizumab over 2 years and over ranibizumab in the first year of treatment. This is in Ophthalmologica, and this is clinical and experimental ophthalmology review article. And in patients with poor BCVA more than 6/12, aflibercept may lead to a more rapid visual improvement than ranibizumab as per DRCR protocol T. And Canadian Journal of Diabetes, superiority of aflibercept was noted in group of participants with worse visual acuity, and the superiority of aflibercept at year 2 with gains of 18.1 letters with aflibercept, in bevacizumab and 16.1 in ranibizumab. And again, there is evidence of a possible difference in drug efficacy in patients with DME to the disadvantage of bevacizumab at visual acuity. So all of us, bevacizumab also with the advent, with the more availability of the biosimilars, of course, bevacizumab use has decreased, but it's not obsolete. Many people are using still bevacizumab. Now, this Cochrane meta-analysis reviewed the evidence from major studies investigating efficacy of anti-VEGF for DME, and it is systematic meta-analysis, and it providing a level 1 evidence-based review of anti-VEGF agents. And at year 1, all efficacy outcomes significantly favored aflibercept over the other two injections, that is ranibizumab and bevacizumab. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab at year 1. And for every 1,000 people treated with aflibercept, 92 fewer would gain 3 or more lines of visual acuity at year 1 if treated with ranibizumab. So this was the Cochrane meta-analysis. And the other meta-analysis suggests aflibercept as the most favorable treatment for patients with diabetic macular edema. This study particularly BCVA change from baseline to week 52, and aflibercept 8 weekly consistently showed evidence of superiority compared with ranibizumab. The same thing as we have discussed the previous slides over there. And aflibercept is most favorable treatment in terms of BCVA improvement and macular thickness reduction. So what we have been discussing, international guidelines and recommendations suggest aflibercept should be the drug of choice in patients with initial visual acuity of less than 6/12. And all these societal guidelines, EURETINA guidelines, ASEAN recommendations, Diabetes Canada guidelines, and German Ophthalmological Society guidelines, all these guidelines echo the same finding. Now, the hierarchy of evidence, all of us, we are researchers, we know that lowest level of evidence is just editorials and expert opinion. However, the highest level of evidence is systematic review and meta-analysis. When making evidence-based decisions for patient care, it is essential to select the highest level of research design available for the specific question in interest. And this will be my last slide, and we can spend some time in this. So basically, why we have put so many protocols of diabetic DRCR.net over there, protocol AB, protocol W, protocol AC, protocol V, and protocol T. And as all of us know, out of these 5 protocols, protocol V and protocol T are most important. And the protocol V saying that if the visual acuity is good meaning how much 6/9 or 6/12, then even if we do only systematic control of diabetes and other comorbidities, or we do focal laser, or we give intravitreal injection of anti-VEGF, all 3 are comparable. And protocol T, as we have discussed, it has been the efficacy of bevacizumab, ranibizumab, and aflibercept, all 3 have been useful and efficacious in improvement in vision and reducing macular thickness in DME. However, aflibercept was better when the visual acuity was less. And protocol AB, as we know, intravitreal anti-VEGF versus prompt vitrectomy with vitreous for vitreous hemorrhage in PDR cases. So protocol AB, protocol W, and protocol AC are not very much practiced, the findings not very much practiced in clinical scenario. But why I have shown over here, all these protocols, they have used aflibercept as the study medications. That's why we have discussed this slide. And with this, I'll invite any questions or discussions on this presentation. Thank you, everyone.
Thank you very much, sir, for your presentation. Is there any questions, or can we move to next speaker?
We can get comments from Subhendu sir, Pooja madam, their seniors are there. They will share their points.
It's a very good presentation, Dr. Chittaranjan.
Yes,
and
ma'am.
you have very nicely highlighted the different protocols. According to your experience, in recalcitrant DME, do you think the DEX implants works better or aflibercept works better?
Yes, ma'am. Thank you for that question. So, recalcitrant DME with particular biomarkers like if we have cholesterol plaques are there, or hard-graded clumps are there, or more number of hyperreflective dots are there, or there is chronicity, that meaning like intraretinal cavities are there. In those cases, I think dexamethasone has some upper hand in reducing the thickness, may not transmit to the visual acuity gain. But otherwise, Eylea and dexamethasone we can use in the rest of the cases.
So I think
Maybe-
what you're trying to say is that if the inflammatory biomarkers are
Yeah.
more than
Yeah.
the steroid implants. Yes, I think I also agree with the
Yes.
approach.
I have a opinion in recalcitrant cases, Dr. Chittaranjan.
Yes, sir.
Many times you are giving the anti-VEGF, you have tried with all the bucket of anti-VEGF options along with the steroid also, even IVTI, Ozurdex, everything, but still you are not getting the result. But sometimes surgery will help, especially
Yes.
vitrectomy with ILM peeling, that helps a lot, and especially surgery. If you do the surgery and you can see I have seen that there is chance of recurrence has gone down significantly. For months, your patient was absolutely not taking any anti-VEGF, not on anti-VEGF, just only blood sugar control and everything. If the parameters are not disturbing his situation, so they are doing absolutely fine with this surgery. But recalcitrant cases, this is only for not for the fresh cases. This is all treatment naive cases. These are only for the recalcitrant case where you have already tried with all the options. 2-3 first generation drugs and 3 second generation drugs. Even with all this trial, this surgery will help. What is your opinion?
Yes, sir. I do agree, sir. In fact, I do like when vitrectomy, I do, and I see a lot of hard exudates. Tend to do the ILM peeling. Even though in VRSI meetings, I have seen seniors sometimes, debating some people for and against of this ILM peeling for hard exudates. But for recalcitrant DME per se, which have not responded, and doing vitrectomy for the DME. Limited number of patients I have done only for DME. But if it is associated with vitreous hemorrhage or other indications for diabetic vitrectomy, yes, I tend to do the surgery.
Actually, Dr. Sangeet Mittal in Thin-Dai Hospital, he has done a couple of cases where there was especially clumping of hard exudate plaques, recent onset in the macula, not very chronic. And there were good results with vitrectomy, ILM peel, and anti-VEGF injections at the end of surgery.
I am also doing this surgery for quite a long time, and diffuse. I have presented my paper in ASRS in 2015 also, comparing the targeted PRP, TPRP versus this vitrectomy, and I've seen that the chance of recurrence has gone down significantly. That is the recurrence of macular edema. Sometimes you will get the absolutely thinning of you can see the only ILM band is there at the center of the fovea, so you have to do the fovea sparing ILM pinning.
Yes.
This kind of situation you will get in your day-to-day practice, and I think surgery will be a when you have rather giving injection every monthly or every 6 weekly. Sometimes it is affecting it means the cost as well as the other factors.
In those cases, sir, only injection doesn't even work.
Yes, that's why the surgery has the role, but still you have to keep it as a last option, not the primary mode of treatment in treatment cases. To try with all these things, and sometimes focal laser, I don't think it is absolutely obsolete. Sometimes if your macular edema is responding, then only you can do the focal laser for the leaky mechanisms to prevent the recurrence, and they also do OL sometimes.
Yes, sir. Particularly as Shubhendu sir told, if the visual acuity is better, meaning 6/9, 6/12, and we can see some aneurysm slightly away from the center, in those cases, non-center
Yes.
involving, we can do laser.
I
Sir,
do a lot of laser in these cases. I'm
yeah.
really fond of it. I mean, if it really
I'm
is
also very fond of doing laser. Is absolutely not obsolete. This is the
No,
standard.
not if I told obsolete, I'm sorry. I think like it's the frequency of injections is
comes
more
down.
than, yeah, maybe.
Yes.
Comes down.
Sir, one question to both of you regarding protocol V, as it has clearly mentioned that if the visual acuity is better, say 6/9 or so, and thickness is more than 300, if we just observe with systemic management, laser versus injection, all are same. So in our practice, do we tend to inject in these eyes, or we tend to kind of observe, or how you manage in these eyes?
Like when it is not center involving, I may wait, or I can try with the focal laser. If it is involving the center, I will go for the injection.
My
Okay.
views are also same. If it is center involving DME, then definitely we cannot just be observing. We need to give anti-VEGF, even though the vision may be good.
Okay. So I'll just share my thought on this. I agree with you partially because I tend to observe in these eyes, and I clearly mentioned protocol V in the EMR. But as you people have told correctly, the center involving eyes, they tend to go for the injection eyes. They need injection, of course, after maybe 2,
Of
3
course, of
months or
course.
so.
I'm not denying the whether in case of center involving DME, you are not giving injection. You have to inject in cases of central involvement. But if it is not central involvement and the vision is quite good, you can try with the focal laser until
Only laser, yes, sir.
fluid is not there and the cystoid spaces are not that. But it varies. You cannot place it in some category. There's so much of varieties in your day-to-day real-world practices. It's difficult to say in a particular pattern that you have to follow this pattern for this patient. It's difficult. It's every patient is very unique, I think.
Yes, sir.
And Dr. Chitranjan, we have two category of patients. One category is who are illiterate. They are not very aware. Metabolic control is also poor. So this will be really detrimental if we leave such cases, because if they come after 3-4 months and then the vision has dropped down, it's a problem. And with very educated multinational, people, CEOs and all those kind of people, also it's at risk, because if it's central involved, they're very particular about the visual acuity they have. And even if from 6/6 it comes to 6/9, then it's a
Yeah,
problem.
they will.
So
Yeah.
that we have to understand in real world scenario. These are the things.
Yeah. Correct. Mr. Nitesh, Mr. Abhishek.
So this is Abhishek, sir. Thank you, sir. Thank you for a wonderful presentation. So I think there's a very insightful discussion was there. So I'm now requesting Dr. Shubhendu, sir.
Should I stop sharing?
Sir, yes, sir. You can stop sharing. So
Yes.
now the session hand over to Dr. Shubhendu, sir. Thank you.
All my sides are visible.
Yes, sir. It is visible, sir.
So, good evening, everybody. My topic is evaluating anti-VEGF drugs, molecular characteristic and their impact on treatment success. Dr. Pooja has already described the APVRS guidelines for PCVs, and Dr. Chitranjan was already showed all the trials happening in the DME cases. So now, I'm just sharing my thoughts and actually the basics of this this drug. Actually, what happened in any kind of hypoxia due to the impaired vascular function because of this impaired retinal blood flow, like in diabetes, there is release of VEGF and PGF. So activation of these VEGF receptor 1 and 2 by VEGF and PGF promotes the angiogenesis and neovascularization. Basically, the VEGF, they are responsible for the neovascularization, and PGF, that is prostaglandin derived growth factor, they are responsible for the inflammatory cytokines and the release of inflammatory cytokines as well as the neovascularization. Both of them can really lead to vascular leakage and the edema. So aflibercept targets the VEGF, that they actually, which is the master regulator for the disease pathology, and additionally targets the key ligand PGF, prostaglandin inhibitory growth factor. So VEGF receptor 1 actually present in the domain 2 of the this immunoglobulin, and it binds to the VEGF-A and VEGF-B and prostaglandin inhibitory growth factor, which are responsible for decreased inflammation, decreased neovascularization, decreased retinal vascular leakage and edema. And VEGF receptor 2, which is present in the domain 2, binds in VEGF-A only, which is other responsible for all these factors. So actually, these aflibercept targets multiple components like VEGF-A, B, prostaglandin inhibitory growth factor, and galectin-1. So the several molecular factors that determine how a drug interact with their body. So it is the binding capacity, number 1, number 2, potency, number 3, elimination of life and clinical targets, and finally the molar dose. So now, first coming to the binding affinity, which determines how strongly the drug interact with its target. If you compare all these ranibizumab and all the second generation drugs, if you see the binding capacity, actually it is the affinity KD value is minimum for the VEGF 165. For the aflibercept 0.172, that has the maximum binding affinity in comparison to ranibizumab and the brodalumab. Padcevinib also comparable to this ranibizumab group. Now coming to this potency. The potency also, the minimum inhibitory concentration 50, IC50 for VEGF 165A, 165. If you compare all these 4 molecules, padcevinib is not available for the aflibercept, is also minimum. That means the potency is maximum for this aflibercept rather in comparison to the other 2 drugs. So half-life is also maximum for the aflibercept, it is 9.1 to 11 days. So these are actually 4 independent studies estimated human half-life comparing to the other like brodalumab, ranibizumab, and padcevinib. Now coming to whether it is single target, it is a brodalumab and ranibizumab, dual target, padcevinib, but aflibercept having multiple target A, B, VEGF-A, B, inhibitory growth factor, and galectin-1. So if you aflibercept significantly decrease the intraocular VEGF and PIGF level from baseline to months 2 in patients with DME. In DME patient, whenever there is exudative retinal diseases like DR, DME, as well as in neovascular AMD cases, particularly in DME cases, VEGF levels, they are given up to 61 times higher, and PGF levels is 19 times higher. So PIGF actually it is elevated. It can activate VEGF receptor, so VEGF activity. So VEGF concentration after single dose of this aflibercept, you can see that after 1 month it has gone from 192 level to 3.2. So PGF also is gone down from 4.4 to 0.6. That means that the inhibitory concentration against the VEGF and PIGF, it is quite significant. So put targeting additional pathways beyond the VEGF receptor pathway further improve the efficacy outcome. Yes, that is the angiogenic factors that they play actually particular critical role in development of edema, permeability, vascular permeability, inflammation, neovascularization, vessel stabilization, everything. They are not only the VEGF-A, B, prostaglandin derived growth factor, also the angiotensin 1 and 2. So these, if you see this chart, and you can understand that in DME cases, it is particularly multifactorial. So the multiple factors are also responsible. Like whether it is like in angiotensinogen type 2 pathway, it's relevant for the target for the treatment of exudative retinal diseases. So it has some debatable, like you can see in faricimab, whether it is acting or not, and to basically in DME cases particularly, And also the exudative AMD and PCV cases, ANGS2 is upregulated. It is competitively binds to TIE2 receptor. So high VEGF stats actually in ANGS2 and antagonistic activity may promote destabilization of the blood vessels. So in low VEGF states induced by the anti-VEGF treatment, ANGS2 may have some limited relevance. So aflibercept is the most potent binder of VEGF compared to the other available agents. You can see. So they are also responsible for this inflammation, neovascularization, vascular leakage, everything. So where and regeneration, they have investigated in ANGS2 pathways in combination with aflibercept in the Ruby and Onyx trees. They are not giving that much of positive result. Whether this ANGS2 are at all, it is very much important for this this pathology, this mechanism. So because they have already used this nesvacumab drug, which is a potent ANGS2 inhibitor for the TIE2 receptor, they have seen in Ruby and Onyx study the role is the no additional functional benefit with potent ANGS2 inhibition in combination of aflibercept. So they are using two drugs, dual, not the like it is separate drugs. One is anti-VEGF, one is ANGS2 inhibitor, potent ANGS2 inhibitor like nesvacumab. So in the Onyx and Ruby trial, they are not giving any good positive result for this. So that means the molarity is also not that much of importance. So unbalanced study designs favoring faricimab and the additional ANGS2 targeting with faricimab didn't confer any additional clinical benefit over aflibercept. But this is actually, you see, it is very like a confusing kind of statement. It is debatable kind of statement. I'm not going to the debates because many more studies are going to come, whether they are actually they're important or not, whether we need more potent drugs also, which can inhibit all kinds of options like against VEGF1, VEGF A, B, prostaglandin growth factor, ANGS2, everything. So we have to wait for the other newer drugs also in the pipeline. So Avenue clinical study also showed that ranibizumab and faricimab achieved similar result in plasma ANGS2 inhibition after one injection. But faricimab failed to meet the primary endpoint of superiority to ranibizumab for BCVA against at 36 weeks, and level of ANGS2 inhibition were similar between the agents, so suggesting that ANGS2 molecular action faricimab may provide no additional benefit over anti-VEGF monotherapy. So which one is important? That aflibercept also shows that showed the most durable and robust suppression of VEGF ANGS2 versus bolocimab and ranibizumab. The result of this if you see this chart and untreated reference anti-VEGF 28 days prior and VEGF 56 days prior, you can see the results of this study supports the hypothesis that ANGS2 may be expressed secondary to the primary insult to the retinal vasculature by VEGF. So direct inhibition of this ANGS2 may not be clinically relevant. That is there lies the fact as this currently provided by the anti-VEGF treatment alone. So aflibercept delivers comprehensive and highly durable targeting, where it matters because of the binding affinity, that is KD value, estimated human half-life. It is also maximum. Molar dose is also quite minimum is required, and multiple of the 4 targets. You can see the 4 targets. That is also important for their effectivity as well as the sustained durable actions. Now coming to this additional pathway, the aflibercept plus nesvacumab, which can inhibit all the 4 factors as well as ANGS2 inhibition, but faricimab, which is having that VEGF A and ANGS2 inhibition. So you can see now coming to the diabetes, where the guidelines actually the laser treatment has been shown to be an effective mode of treatment option in the management of DME in the early pioneering studies compared to the sham injury treatment. But currently in the era of anti-VEGF, it is clearly it is not the standard of care. We have already discussed the thing that the diabetic macular edema treatment guidelines in India. We have already discussed that by the AIOS that intermittent injection of anti-VEGF agents are the first line of treatment of central lumen DME, but laser, focal laser is not absolutely obsolete mode of treatment. So RCT-like outcomes are also possible with aflibercept in clinical practice. There's been already Dr. Chittaranjan highlighted the Moorfield study, Monimoto study, and in DME Moorfield study is also there. Explained in details they have already discussed. I'm not going to the details. Now I'm coming to my situations in my clinical practice, where it is 86 years old, recurrent CNVM, grade 2 cataract, right eye vision 6/12, left eye 6/36, bilateral, not treatment naive. It is a like switch cases. You can see the after repeated intravitreal anti-VEGF injections with ranibizumab and as well as the brolucizumab injection, it is behaving it is stable. But when there is still recurrence after giving in all this, I have switched to the first aflibercept, and in this situation, you can see after giving the first injection, it is very interesting. It's like one single injection in the month of February, in the month of January in 2024, the CNVM has regressed significantly. But after that, when there is like recurrence, when there is this is recurrence that happened in the May 24, I advised this patient for the second dose, and the patient didn't turn up. He lost follow-up due to some systemic problem, and again he came back after 18 months. And you can see I did Octa in that patient. The right eye is still doing okay. I have not given the injection, but left eye you can see the open loop configuration of the CNVM, and there is some kind of pedicel halo. And in here also in OCT, there is large cystoid patients, subretinal fluid. That means their activity is still there. But still, you can see after a single injection of aflibercept that I have given almost more than 18 months back, this activity has gone down. This is giving kind of open loop CNVM pattern. That means it is not that much active. Still, it is some fluid is there. So I advise the surgery for the injection. Now coming to another interesting case, it's one-eye PCV cases. In the left eye, you can see after giving multiple anti-VEGF injection, there is a large RPE that is there in the temporal part of the macula, and you can see the RPE in the ear. Vision is quite stable, 6/18. Now, patient presented with the recurrent CME. So I have given the first injection, and you can see a lot of cyst spaces. It's gone absolutely vanished after giving the first dose. And after 4 months, the patient came with the recurrence of edema, and I have again given the second injection. So again the edema is absolutely vanished. Only the PED is still persisting. So when there is again a recurrence of CME, so I have given the third injection, and the PED part has totally flattened. You can see not only the CME, also the PED, which was persisting in the previous visits, but this PED has almost flattened, and vision has more stabilized because his one-eye vision it was 6/18 parts, now it is 6/18, 6/12 parts. And again, there is some kind of recurrence in the month of January 26. Now I have given the fourth injection. And after giving the fourth injection, in the month of February, you can see the CME has again vanished, and it's absolutely regressed. And now the patient, last visit, there was no recurrence of this edema. Patient advised the patient for the cataract surgery, and it just I did the cataract just in the last week. Now coming to the DME cases, is the case of DME 10 years. For diabetic for 10 years, case of severe NPDR with CME, and you can see the right eye, the CME pattern is absolutely atypical, not just like in the other situations, few cysts in the mid retinal segments, not in the outer retina, and one large cyst present in the inner retinal layers. And you can see in the left eye also is a single kind of situation, cyst with a thickened neurosynaptic retina, the center involvement DME. I have given aflibercept in the both eyes, and you can see left eye responded so nicely, but in the right eye, CME part has gone down this little bit, not significantly, I should say. In that, with my second injection also, the CME pattern has reduced much, and after third injection, it has almost giving the very good result. But still, it is the last visit. I have advised the patient for the second again the fourth injection, but the patient is yet to come. So in summary, there is comprehensive targeting is required because aflibercept targets not only the VEGF, and VEGF receptor 1 and 2, but also the prostaglandin inhibitory growth factor as well the galectin pathway. And this VEGF receptor 1 and 2, which is the master regulator of the pathological angiogenesis, to date, both preclinical and clinical data suggest that no additional benefits of targeting alternatives to the VEGF signaling pathways. The separate independent studies also suggest that aflibercept has a higher binding affinity to VEGF-A that has already proved with multiple RCT as well as in the real world scenario, the greater potency, longer half-life. So with is rather another thing you can. Another potent drug is, I should say, it is brolucizumab. That is one of my favorite drug, brolucizumab. But still, I should say, brolucizumab has the concern of IOI, but this Eylea, I don't have this concern of IOI. So it is also safe. Even one-eyed patient also, you can give this kind of drug with like safety also, not only efficacy, and most importantly also safety, because patient should not lose any kind of vision, whatever he or she had. So targeting alternatives, that's not required, but high durability absolutely is important for to reduce the cost burden. Thank you.
Thank you, sir. Thank you for sharing your real-time experience, and thank you for a very insightful presentation. So now the forum is open for the audience, and special for the from Pooja ma'am and Chittaranjan sir, if they have any kind of questions or any point from their end. So now the forum is open for the audience.
Very nice cases you have shown, and an excellent presentation. Sir, regarding that large PED case that you showed, and the RP RIP, was it post injection? Was it because of brolucizumab?
Post injection, not brolucizumab. We have already I have not given that brolucizumab in that one-eyed patient. I have used that ranibizumab and the biosimilars in that patient.
Okay, sir. So that was just incidental that there was a RIP. The
RIP was there. Yes, when he when we have started the Eylea, that RIP was there, and after giving this RIP was not extended much. Basically, in presence of RIP also, I think the chance of responsiveness of these drugs are reduced. But in my case, it is every time I'm giving the injection, the edema was it was reducing so nicely, and finally it was almost becoming the flat kind of situation with the third injection, I think so.
Yes, I think that really went well.
Even I have seen I have my cases like where the PED has become almost flattened, like I have seen on with all the anti-VEGFs. I can tell you only two drugs they can flatten the PED. That is, one is brolucizumab and second is Eylea. This aflibercept. These two drugs is very important for flattening the PED, because in absence of CME, intraretinal cystoid changes and the subretinal fluid, PED per se it is not important to treat the case. But in presence of all three factors, the PED flattening is also important, because to reduce that means it is responding. The disease is responding as a whole. So when the CME, that intraretinal cystoid changes and subretinal fluid is vanishing, that may in side by side the PED flattening effect should be there to read to assess the actual effectiveness of your treating drug. So rarely also, I should say, faricimab also very rarely. This because one of my cases I have tried with everything. The PED was not fattening, but even after two injections with faricimab, the PED was not the fattening effect of PED was not visible in OCT. But after giving the third injections, the magical treatment with this third dose of faricimab has happened. But for this aflibercept, this is very regular thing. I should say it is very regular thing because that's why in ASRS also they have discussed long back that the PED flattening effect, especially in case of PCV, it is they're considering in PCV is the drug of choice because in the ASRS that practice pattern, they are taking the opinion from all corners of the world, Southeast Asia, and as well as the overall USA, Europe, and all the Australia, New Zealand, all these corners of the whatever they are giving, all are giving the number one choice for PCV. It is the aflibercept. There's no doubt for the PCV, which is more aggressive, more risky, and it's not that uncommon. Whatever we thought previously, it's quite common PCV.
Yes, sir. And what you said about faricimab, maybe we all know there's no wow effect in it. So maybe that is because of that reason, by the time you gave your third injection, the patient responded.
Responded magically.
Yes.
Sir,
But
regarding
that happened
RP,
in one of only a single case for me. But for Eylea, it is quite regular.
regular.
PED flattening effect is quite regular. It is not it's once in a situation.
Yes, sir.
Sir, may I ask one question? Like the RP REAP, for the benefit of our viewers, any according to your experience, any particular biomarker which is kind of more predisposing to this, or any anti-VEGF which in a combination of these biomarkers, so we should be more careful for this combination?
Basically, RPD happens on those situations where the RP is tall PED,
Very
tall
true.
notched PED. Especially in PCB cases, tall notched PED, they are more vulnerable to go for this RPD, this kind of situation. And only not other than the OCT, if you do the FAF also, you can see the RPD nicely.
Okay.
Only in the OCT, if you see the notched PED, tall PED,
We should be careful for this.
very careful. And you are using the strong anti-VEGF.
Yeah.
Strong anti-VEGF, and there is tall PED.
Tall period. So these two
This
combination
is very deadly.
And especially with brolucizumab, one is a little scared.
Right.
yeah.
So I think there is no other question from the audience side. So it's a very insightful discussion was there. Thank you, Shubhendu sir. Thank you, Chittaranjan sir, and thank you, Pooja ma'am, for your valuable time. And there's a benefit for the entire audience. So hopefully we will be able to conduct this kind of meeting for the benefit of the society, for the benefit of the audience. So again, thank you for your presence. Thank you, Shubhendu sir. Thank you, Pooja ma'am. Thank you, Chittaranjan.
Thank you so much. Thank you so much.
Thank you.
Bye.
Thank you.
Thank you, ma'am.
Thank you.
Thank you. Thank you all.